Good evening, everybody, and welcome to today's episode of Marvelous Medicine. We are extremely privileged to have a stellar audience today, and the topic is an important one, which is about communication skills for everyone, but we'll do a little extra focus on doctors. We are very privileged to have Dr. Indu Arneja as the moderator. She's an author, educator, and founder director of the Indian Institute of Healthcare Communication, an organization that is dedicated to strengthening patient centered healthcare through communication, leadership, and team building programs. She's a nationally recognized expert in healthcare communication, and she serves as a core group member of the advisory board on health and mental health for the National Human Rights Commission. She has been a visiting faculty at several prestigious institutions, including Indian Institute of Management, Ahmedabad, XLRI, Jamshedpur, All India Institute of Medical Sciences, Delhi, and Public Health Foundation of India. Over the course of her career, Dr. Indu Arneja has conducted more than 2,000 training programs, impacting over 50,000 healthcare professionals across India. She is also the author of the widely appreciated book, Fundamentals of Clinical Communication Skills, a step by step guide for medical students developed specifically for the Indian medical education context. In 2021, she received a prestigious scholarship from the Academy of Communication in Healthcare in the United States and became a certified relationship centered communication facilitator. Through her pioneering master trainer program and regional training centers in collaboration with Orbis India, she continues to build capacity in healthcare communication across the country. Thank you, Dr. Indu, for immediately accepting to be a moderator for the session. Some of you might have already heard Dr. Indu as a speaker in Marvelous Medicine more than once. We always think many of us think we have communicated well, but it may not have reached the patient or the family. So we thought it was extremely important to have the perspective of patient party, if you like. And we are privileged to have Miss Madhu Mathur. She's a postgraduate in child development from the University of Delhi, and she's won the National Award for writing stories for children in English at the age of 23. Her life journey has been deeply shaped by years of caring for her severely disabled daughter, involving extensive interactions with hospitals, ICUs, and healthcare professionals across India and the USA. Beyond caregiving, Madhu is a writer, painter, educator, and award winning quilt artist whose experiences have given her profound insights into empathy, communication, and the human side of healthcare. So, we look forward to her invaluable perspective of a patient's attender, so that we can understand how to do compassionate, patient centered communication. I request Dr. Indu to introduce Colonel Hari Krishnan. I am extremely happy that he immediately accepted to do this session. We are very privileged to have three people who have published books on communication in healthcare. Professor Sethraman having done it way back in 2001, and after that Dr. Indu, and then of course speaker Colonel Hari Krishnan. You're all in for a very, very insightful session. So over to you, Dr. Indu.
Thank you, Dr. Vidya and Marvelous Medicine, for this golden opportunity to interact with such an august audience and listen to Dr. Hari Krishnan's talk. And I've read a couple of his chapters and I found them so insightful and so interesting and engaging that I really felt honored that I have been given this opportunity to introduce Dr. Krishnan and also, talk about the topic. Of course, this topic is something very, very close to my heart. Decades ago, I think communication was never something that was really asked for. Probably patients had a lot of faith and they never asked for anything more than just being treated and given good care, that's all. But I think with the changing time, the need for communication, need for understanding patient's perspective, need for understanding what patient's challenges are, has really brought in this insight that just treating the patient is not enough. I think understanding the patient, understanding their concern, and also understanding what will work best for the patient with the understanding of patient's commitment or also adherence to the treatment is something that we really need to look into. And I think in today's healthcare environment, communication is no longer optional. It is clinical competence that's not enough to build trust or ensure compliance or prevent, conflict. I think today's session by Dr. Hari Krishnan is going to be an enlightening one because we will understand from his experience and years of decades of experience with patients and their family members that how patients really long to have some discussion with the doctor, some understanding from the doctor about their condition, what are you going to do, why not this, why that. So I think this discussion is going to really help us all understand that it's not soft skill. I think this one clarity we all need to have. I mean, normally when I speak to people, they say clinical communication is soft skill, and I really feel sorry for that because soft skill is just one part of it. But truly clinical communication is accurate diagnosis by taking proper history, then making correct diagnosis by explaining to the patient, understanding patient's concern, addressing their concerns, sharing, practicing shared decision making, and a lot more than that. So I think today's session is going to be a great learning experience for us. I don't think Dr. Colonel Hari Krishnan requires any introduction, but I think for those of us who are meeting it for the first time, although I could see almost everybody knew him, so I don't think anybody looks for his introduction, but I would be honored to actually introduce him as a speaker for today's session. He's a distinguished GI and laparoscopic surgeon from the Indian Army Medical Corps with extensive experience across India, UK, and Oman. He's a graduate from Maulana Azhar Medical College. He has advanced surgical training from AFMC Pune, AIMS Delhi, and AIMS Chennai, and also holds an MBA in healthcare management. Following a distinguished army career, he served as a consultant colorectal surgeon in the NHS UK and later as senior consultant and medical director for a group of hospitals in Muscat, Oman. He is deeply committed to quality, patient safety, and enhancing communication skills among healthcare professionals, and has been associated with academic institutions as a visiting and adjunct professor. A prolific writer, globetrotter, music enthusiast, and bibliophile. Dr. Hari Krishnan has authored several books and numerous professional papers, including his work on healthcare communication. He currently divides his time between Bangalore and London, balancing his professional pursuit with his passion for animal welfare and love for his grandchild. Dr. Hari Krishnan has recently published a book called Thank You for Listening. I have read the first few chapters of the book and find it extremely useful for one and all. I would really recommend everyone to have a look at the book because the way he has brought in the nuances of communication, that's really very beautifully, done by him. I would really recommend everyone to read his book. Sir, I would actually look forward to have the whole book from you and read it, but definitely it was really very engaging and interesting. I'll not take more time. I know I can go on and on talking about his achievements. Sir, over to you to please share your learning and your experience and expertise with all of us. Thank you, sir.
I have a small request. I request everyone else other than Colonel Hari Krishnan to mute themselves. And if your camera is on, please avoid moving too much because then the video will capture your movement rather than Colonel Hari Krishnan. Thank you for your cooperation. Over to you, Colonel Hari Krishnan.
Thank you, Dr. Vidya, and thank you, Dr. Indu, for a very nice introduction. And a very warm hello to everyone. I'm actually humbled that many of my teachers and seniors are here, some on my invitation, some on their own. And it goes to show that I am very, very privileged to have grown up in a milieu like that. Thank you very much. I start sharing the slides, Dr. Vidya, now? Right. I would like to begin with a bit of an acknowledgement. But even before that, I need to tell Dr. Indu, I do apologize. You mentioned that you read 2 chapters of my book. That's because when we got in touch with one another, I realized that there wasn't enough time to send you a copy of my book. So I sent you a PDF file, which I thought was the full file, and apparently it contained only 2 chapters. When you wrote to me saying you read the 2 chapters, I tried to go through why only 2 chapters, and then I realized I had sent you only 2 chapters. My sincere apologies. Your book is on the way. So let me start with an acknowledgement that this has been for the benefit of not just the medical people, but also for the general public who are listening in. There is a heavy amount of workload for all staff in healthcare. So there's a lot of time pressure that all healthcare workers work under. There's a massive amount of ever increasing documentation that we need to do. And on top of all this is administrative expectations, especially in the corporate sector. All these things are very important to bear in mind for what we are going to discuss in the latter part of the presentation. I also, as I said in the beginning, acknowledge the presence of a composite audience today, where I'm hoping that in addition to Madhu, others from the patient's perspective side of the story will be able to share their experiences or make comments on such things as I'm going to be talking about. So I'll try and see that I do not take too much of your time. Please bear with me if I do. So what we're not going to do today is go through a lecture on communications. I'm not going to talk into types of communication and benefits and disadvantages and things. That's for the future, for the students, and there are enough and more books as we already learned. We are going to just look at what we already do every day, which involves communication, and how we impact ourselves, our students, and how a few small changes here and there can make a big difference to how we deal with our commitment, our oath, our responsibility towards our patients. And I'm going to definitely touch in the end on how the Indian healthcare system, which is one of the finest in the world, can not just be world class, but also can be humane at the same time. That's one thing that I think we are a little concerned about, most of us who are willing to reflect. Above all, I would like to tell the medical people present here that I'm going to be talking a little bit about what our patients want from us. And I know that among other things, they want us to do a little bit of reflection, and that should be in the form of how many of us of the medical fraternity sitting here in the audience today, nurses and students, feel that nurses and students need better communication skills. This is not a poll. I don't want hands up and things like that. I just want all of us to just mentally think, is this a question worth addressing? And if so, what is the answer? Because the next thing is going to be, how many of us, amongst the senior lot especially, were actually trained properly in communication? How many of us had the benefit of, say, going to Dr. Indu's sessions? I have not been. I don't know how many of us have been in this process, but I would say that a very, very minor number of people in the medical fraternity sitting here would have undergone specific communication center training. Correct me if I'm wrong at the later end. And therefore, I'll start with a question addressed to not just the doctors, but also to the entire medical and non-medical people present here today. Let us close our eyes for a second and think of our own last visit to a doctor as a patient. Did any of these things happen? Did the doctor say, hello, come in, my name is so-and-so? Did you feel when you left the audience of the doctor, when you left the clinic, did you feel reassured? Did you feel relieved? Or did you go out feeling a little bit more anxious than what you actually went in? It's worth thinking about. And I think if we are honest to ourselves, a fair amount of the answer would be very, very important from the point of view of why we are discussing this topic all over again. I asked this question in the form of a Google form to quite a few people. And I had a fair bit of response. And the percentage of response from the number of people I wrote to among the general public was very high. But without going into the details of this lovely looking chart, I can just tell you that majority of them wanted that they should be listened to, or they should have the benefit of walking out feeling that they have been explained their illness. This was an answer to the question, when you visit a doctor, what matters most to you? When I asked them, what makes you take to a doctor? How do you endear yourself, or the doctor endears himself or herself to you? And how do you trust them most? The answer was very similar to the previous questions. It all boils down, if you look through the I mean, if you read between the lines, it all works down to the doctor communicates well with me. So today I'm going to give you two contrasting stories. One is a not so happy one. I've said bad, actually it is, but I would be polite and say not so happy one. Then we'll go on to a very good one so that we know that there are always two sides to a coin. I am not sure if time will permit, but if it does, I'll give a couple of examples from my own interactions in the UK and Oman, which, as you heard from Dr. Indu, I've had plenty of opportunity to observe and work in. Let us just look at this couple for a few seconds, generated very happily by ChatGPT for me when I gave the prompt. And this is Mr. and Mrs. Patel. As you can see, they are waiting in a clinic. You can read their expressions of mild anxiety in their face because they're waiting to see a doctor. Now, this elderly couple was referred by their general doctor, their family doctor, because Mr. Patel was complaining of breathlessness and a bit of discomfort in his chest, which he tried to ignore, but his wife would have none of it. So they insisted, the entire family insisted that they see the doctor. The doctor said, listen, I know that you're very fit for a 73-year-old, but why don't you go and get it certified by a cardiologist friend of mine? Then everybody will be happy. So go. So they went. They went to a hospital, they registered, paid the money or whatever, and then waited. After some time, a junior doctor came and spoke to them, and then he ordered an ECG and an echocardiogram, which was duly done in the next few minutes or half an hour or whatever. And then they continued to wait for 2 hours. There was no update. There was no follow-up. There was no news from anyone. And being elderly, they were beginning to feel a little uncomfortable, probably hungry. So they decided to go to the receptionist and ask what happened. And the receptionist looked a little bit surprised and then said, oh, I'm sorry, the doctor is in the cath lab. All right. When will he be back? The answer was, oh, he won't come back here. He is going off to the super specialty hospital after that. He has got a clinic there and he has got work there. Why don't you come back on Tuesday? And this was a Saturday. At the end of 2.5 hours, just an ECG and echo later, no visit to the doctor for which they came primarily. They picked up their new appointment, but next morning they went to their doctor, general doctor. This is not the general doctor. Let me go back to the previous slide so that I don't confuse you. They went to their family doctor and said, what is this? You sent us to the best doctor in town, you said, and we waited for nearly 3 hours total and nothing happened. We didn't even see the doctor. What are we supposed to do now? So the doctor did some damage control, looked at the reports and said, you know what? I think based on these reports, I'm not an expert, but I will get one more investigation done. It's called a CT angiogram. You will then be referred by me to the doctor. Unfortunately, he didn't say which doctor. That was a small mistake he did. Otherwise, he's a wonderful man as per the Patels. Now, I'm saying this because this is not a fictional story. This is the Patels, only the name is fictional. The rest is all absolute verbatim from the people concerned. So they were referred back and they had a very quick consultation this time. After, of course, waiting for a fair while. Just let me give you a picture for you to stare at and observe certain things that could have been better, which we'll come to in a second. They were sent to a cardiac surgeon. They didn't know that. When they had the usual wait, and then when they went in, the surgeon did not greet them. He made up for their long wait by making the consultation shorter than 30 seconds. He said, well, you need a bypass and you can talk to my assistant outside and fix it up. I'm willing to do it any day after Monday. And he picked up the next file. They were gently herded out by the nurse in the room. But as you can see, this time they were accompanied by Mr. Patel's brother, who is a sort of a CEO of a company. So he feels a little bit more responsible and capable of asking questions. So he went back in and asked the doctor, Doctor, why? What is this bypass? Why bypass for my brother? Nobody told us anything. And then he was stopped short at that point. The surgeon looked up at him for the first time and said, Listen, I don't have time for all this nonsense. Why don't you talk to the people outside? You can see I have a lot of patients waiting outside. And by the way, if you don't want to get operated by me, it's fine by me. Please go anywhere else you want. This is a verbatim report. I have not even altered one bit of what I was told by the same people. So they simply tucked their tails between their legs and walked out of the hospital. But they never returned. They didn't want to see this doctor. They didn't want to come back to this hospital. And then they also went out of the way to try and dissuade others from coming to this hospital or to see this doctor. Now, this surgeon is extremely well known and a wonderful man who is supposed to be actually a magician inside the operation theater. So what I'm trying to say is when they went out, they didn't worry about his titles, his qualifications. They had heard about all these things. None of that stuck in their minds. They didn't even probably remember exactly what it was that they'd been told, but they remembered that they were not even offered a chair to sit in when they were being told a life-changing surgery it was being offered. So patients remember more of the how rather than the what is the bottom line of patient perception of our work towards them. This begs the question, can a technically brilliant and accepted superhero doctor also be sometimes labeled as bad or useless or not desirable by our patients? I leave all of us to find an answer to that ourselves. So if you were to just do a little bit of reflection and wonder what went wrong in this consultation, it's very easy to summarize it by saying everything. From the first visit to the cardiologist, then to the surgeon, nothing went right for the Patels, but not on the medical side. They were told the right thing. He probably needed a bypass based on the echo and the angio and the ECG. But poor communication put paid to all that wonderful bit of knowledge because they were not impressed. Now, if I were to ask the audience, could things have been different? I don't know that I would even have to wait because I think the answer would be a resounding yes. Everybody would want things to be done differently. I'm sure of it. The reason is that communication matters. We don't think so very often, but it does because it does all of these wonderful things, especially building that connection between us and our patients, which leads to so many benefits, some of which Dr. Indu mentioned even in her opening statement. And the idea is that a sense of partnership in the healthcare process develops between the patient and the doctor when we communicate well. And it leads to a lot of benefits. I'm going to flash a slide sooner about the importance of that, the second last line here. But more importantly, here is something which some of the juniors might find very interesting and surprising. The clinical outcomes improve. All of these things happen, and this is again not something written in a slide to impress people. Because if you were to do a search using the prompt shown at the bottom of the slide, you will find any number of articles from all the reputed big hospitals and investigative setups in the medical field in the form of evidence-based medicine, saying that things like the insulin requirement goes down, cardiac and pulmonary functions improve in patients, but with the same treatment under a different umbrella of conversation. Now, that conversation is all that matters to many people in terms of overall performance. That is the thing that we need to internalize. Now, I said that I'll take you to give a few examples about from UK and Oman. I'm going to put this slide on hold. Let me see how I perform in terms of time, and then I'll come back to this. So let me tell you a lovely, happy story now for a change. I wanted to get that bad story out of the system. That's why I went for that first. And incidentally, this is also an absolutely clearly documented, personally communicated story. There's no fictionalization here in this. This is Mrs. Solka in the picture there with her husband, and she was, like most of us, terrified of going to a dentist. But she was coaxed by a friend. No, 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 please go and see. You have been suffering for the last so many weeks or months, I don't know. Go and see this doctor. He's a wonderful man. You'll be happy. And here, when they walked into the clinic, they found a very smiling young receptionist who put them at ease and won them over by saying, please sit down. Here are a couple of bottles of water for you. I'll quickly go and find out if the doctor is free. And she goes in and comes back soon and says, the doctor is getting ready in a couple of minutes. He'll call you. And sure enough, they get called in. And when they go in, the doctor and his assistants, who are obviously wearing masks and things because they are doing procedures, they pull down their masks and introduce themselves. And then they say, hello, I'm so-and-so. Come in, Mrs. Solka, Mr. Solka. And then they make them sit down. Mr. Solka is offered a chair and they start talking about the issue. He's already been briefed by his assistants. So he says, I'm going to do a procedure for you. Now, the first thing that she wants to know is, will it hurt? He says, yeah, it will hurt a little, but going by the history that you've given us already, it's going to hurt much less than what you've been going through all these weeks. So don't worry. I'll give you a small injection to numb the area, and that makes her jump again. Injection. Won't that hurt? So again he says, well, I can't lie to you, it will, but I'll use the smallest possible needle. And you know what? What if I asked your husband to hold your hand while I give the injection? I'm sure the pain will be less. She gives a smile. The whole thing happens as he promised. And then half an hour later, whatever procedure was done, that's not important for us. She is done and dusted, but she's a very happy person. So the first thing she does after thanking the doctor and the nurses is to call her friend and say, thank you very much for referring this person to me. This doctor is wonderful and the clinic is wonderful. I'm going to tell everybody about it. So in this instance, as with the Patels, if you were to do a little reflection and think instead, what went well? The answer is the same. Everything went well. And not just on the medical side, because here the most important factor was the great level of communication that was exhibited by everybody involved in the process. I've taken these two examples because this is how we can win patients over and make a great impression on them, not just with our technical skills. So here the question, if I were to ask the audience, do you think anything could have been different? The answer is very likely to be no need. Everything was fairly okay, because we are not expecting VIP treatment every time we go there. We want reasonable treatment as patients. I'm talking about as patients. So if you compare the two and wonder what it was that was different between the two sessions of experiences, the answers are already given there on the right side, but the most important thing is the body language, eye contact. And that sets the tone for what follows in a consultation. And then it begs the question, what would our peers and juniors learn from the experience in the consultant's room in the hospital, the cardiac consultant's room, and from the dentist's room? If there were two juniors training simultaneously, which direction would their character go? Which direction would their empathy go? I think it's really, really important for us to ruminate on this. Because once one side, the person may get a wrong impression of how to conduct himself. On the other side, the person will get a very different impression of how to go about his business of being a doctor. And this will be completely at odds with the curriculum proposed by the National Medical Commission and which we might want to follow in the form of lectures and booklets. A few months ago, the eloquent Mr. Shashi Tharoor placed these statistics in the parliament. I'm sure many of you might have heard it. And it's a very distressing set of statistics to see, but the uncomfortable reality of it will be underscored by this picture. Some of you might remember just about 2023, late 2023, there was a march taken out by many doctors in India. They walked up to the Rajghat saying that there's too much of violence against doctors and nurses and hospitals. Times of India took it up. One lady wrote a beautiful article and she actually tried to explain why patients get agitated wrongly without knowing things. I will not go into the details, but the point I'm trying to make here is that very often what is missed is that these things could have been avoided. The violence, instances of violence could have been avoided had there been proper communication. Example, somebody brings their moribund mother or father to the hospital, they are admitted in the ICU and they are told to go get this, do that, bring this, and this is the cost, and the outcome is bad. The outcome being bad has nothing to do with what was done in the ICU. Probably the best was done. But when the outcome is bad, all this, go get this, do this, pay that fees, sounds like an insult. And it brings on anger. And then when there are more people than one in the family who are waiting outside the ICU, it turns to mob mentality. Whereas, had the same thing been done, listen, your mother is in a moribund condition or your father is in a moribund condition, we are going to try our level best. These are the things that we think could be the reason. We'll try our best, but please believe us that there is a possibility that things may not go the way you and I want, you and we want. And that would have made a difference to how they react when, if the outcome is not what they wanted to see. Now, the interesting thing is the situation changes completely depending upon how much the patients trust us, and therefore the chance of being sued by a patient who trusts and believes that we are doing our best, which we are naturally always trying to do. Now, patients don't sue such doctors. They don't attack such doctors. At least I hope so, and I think in the majority of instances, this is more likely the case than otherwise. I started by asking how many of us have had structured communication skills training. Now, we all know that all of us, the senior lot, we either learned or the youngsters are learning from us communication by observing others around us and adding a little bit of our own experience, because sometimes we come across good and bad experiences for various other reasons. And then we slowly build our own model of how to communicate with our patients in the coming years of our professional career. Elementary students will learn the same way. And whether we like it or not, whether we are conscious of it or not, students and our peers, our juniors, our nurses, our residents, they observe us, how we talk to patients. What is our tone? How do we deal with our own colleagues, nurses and the students and the paramedics who are milling around us all the time when we are when we are at work? How do we interact with other colleagues from different departments? Do we have a congenial relationship with them or do we argue with them? And above all, how do we react when we are under stress? Which, as I said in the very first slide, is a very common thing in our profession. Now, all these things cannot be learned. by just listening to lectures on communication skills, which is why I chose that there's no point in giving a lecture. I do that for medical colleges when I go for lectures, but this is not the intent because that is not enough. Our responsibility lies in being good role models, because the key idea is that we are teaching communication skills every single day, with or without realizing that we are sending such signals across through our body language and by our actions and by our speech, but more importantly by the body language. And if students and residents see such wonderful examples as the Solkers went through, then all we will need is these OSCEs. For the benefit of the non-medical people, these are objective structured clinical examinations. What it means is you go through a series of observations by examiners to see what your level of clinical improvement is. And in the UK especially, I've been part of it, I know, therefore, I'm sure it's there in most European countries and in the US as well. The first station for an examination in many of the undergraduate courses is a observation station. It doesn't even have the name of communication skills, because students are simply asked to go in and meet the patient. They're not even told what they need to do. And the examiners don't ask any questions, they simply observe them. Do they greet them? Do they introduce themselves? Do they warm their hands before touching a patient if they have to examine the abdomen? How do they react? What do they do before leaving? Do they leave the patient saying that, I don't know what's going on with you? Or, I know everything about you, you're going to die because you got cancer? All these things are observed, and believe me, these things happen. So when I did a workshop recently in Chennai, that's the time I went and had the pleasure of meeting Dr. Vidya face to face first time. The group of faculty were divided into groups, and each group was given one task. Some of the doctors were to be doctors, some of the doctors were to act as patients. And in each of these, we asked these questions. How do we handle this? For instance, how do you break bad news to this person who's got a cancer of the throat? What could be done differently from the way we conveyed this or handled an angry relative or consented a patient for high risk? And how should we teach a junior, or how do we convince a junior to handle this in an appropriate way? Now, I can tell you that this happened in the medical college, where I was so impressed by the person who was given the task of taking a consent for a high-risk surgery, because he started by talking in the language of the patient, which you may not always have the benefit of, but you can try, and using only non-technical words. Many of us are guilty of using jargon, technical terms, without even realizing that we do that. So this person was very impressive, and when I told him that, he was so happy. I think he has been won over as one potential fantastic communicator for the rest of his life. Now that's something very, very satisfying to me. In fact, I will tell you this, the whole thing, halfway through, when I suggested that we can stop here if they want, they said, no, we want to continue, because it was such a happy and comfortable way of group learning and group role modeling, that we had actually extra sessions, especially in the interdepartmental conflict. The vice principal of the medical college suggested one more session, and so we went on to do one more exercise of that. So what I'm trying to say is, an exercise like this once in a while opens up our minds. I learned a lot, many things that day, as well as I was trying to open up others to learn. So here is a 5-minute teaching tool. I would like most of the senior law to please see if you can incorporate in your way of life on a regular basis. After a difficult or a distressing or an interesting session, the thing would be to ask some of the juniors, so what do you think was the patient's main worry? Was it the diagnosis? Was it the possibility of losing a job or something like that? So It opens up their minds. What else did you observe? Is there anything we can do better when a similar patient comes next time? What would you do if you were sitting in my chair as a consultant? Now, these are things that will make them think instead of rather than simply going back to pick up their books and finding out what they should do for this cancer or that investigation for that particular joint pain or whatever. So it's a sustainable suggestion, in my opinion. It need not be done every day. It need not be done even every week. It can be done once in a while as per the time factor available to people. But a communication skills discussion could be done like any other grand round that we do. And that one case should be discussed in such a way that it conveys the essence of what we are trying to do to our cohort of doctors and nurses. It should not be a blame game. It is not a question of finding faults that you didn't do this or you didn't do that. Could we do this? Could we do that? And at the end, there might be opportunity for everyone, including the person conducting it, to reflect a little bit. Like I said, that happened to me after the workshop. So on balance, there are a few things that are sacrosanct, and one is that the lack of information given to the Patels at the end of 2 hours, the information given to the Patels at the end of 2 hours saying, oh, he's gone to the cath lab, which didn't make sense to them anyway, and that he won't be coming back, was no use because the delay was as good as no communication. If somebody had said, oh, the doctor is already gone, let's go and tell 2 or 3 patients who are waiting for him that he's not likely to come back, could they come back at a later day? That would have been very well received. No patient ever likes being told that the doctor had to rush off to save another soul, save another patient. People always sympathize with that possibility happening to somebody else. And so they actually wish them well and say, no problem, I'll come back tomorrow. But don't tell them. They say, this man didn't even bother to tell, this nurse didn't even bother to tell, this receptionist was useless. Because every patient believes they are a VIP, very important patient. So, explanation of the situation is as good or as important as the treatment part. Because that underscores the empathy that we show towards our patients, and empathy is everything. And this was very beautifully quoted by Dr. Richard Frankel from Indiana, USA, many, many decades ago. And he said this, and believe me, I feel we all may be partly guilty of this. We all start our medical career thinking, I'm going to cure everybody who I see. I'm going to be the best doctor in the whole world. But we misunderstand what best doctor is. Because we pick up so much of information, so much of diagnosis skills, somewhere along the line we lose touch with that true meaning of the word best doctor. So we end up having people who don't care but who are extremely skilled, the cardiac surgeon as reference. I'm just saying that as an example. Please don't misunderstand me. This happens in every specialty, in every hospital, in every part of the world. Those of us who are from different parts of the world sitting in the webinar today will know that I'm not exaggerating. So, for the benefit of our general public who are listening, I would like to mention one thing. You must be wondering, why is it that then doctors lose this empathy? Why do they become like that when they become so talented? It's partly because of the training process. We are all the time focused on diagnosing the disease concern because we think we are doing the great thing or the best thing by our patients, which is partly true. Medicine is also an outcome driven system, especially in the corporate world, and a lot of pressure is put on outcomes rather than the methodology. And as I told you right in the beginning, time pressures and stress are part and parcel of our everyday life for all of us in the healthcare department. And believe me, we doctors and nurses do come across patients who refuse to show the slightest sense of gratitude despite everything we do in their benefit, in their on their behalf. and sometimes they are outright rude. And there are enough examples of this. Dr. Indu referred to my book. I've devoted a separate chapter to this about how patients have their rights, but they also have their responsibilities. Now, empathy, as I mentioned in the previous slide, is more about the intention rather than spending 1 hour extra with each patient. As sometimes I get asked, how can you expect us to be empathetic when we are seeing 100 patients on a daily basis? No, it's not about spending 1 hour plus with every one of those 100 patients. It's ridiculous, but it is important. For instance, take the example of a excited young resident saying to his friend, I'm operating on the gluteal abscess in room 106. That's my first case. Yay. But he's forgetting that he's not being empathetic. That gluteal abscess surely is attached to a Mrs. Gupta or a Mr. Sharma. So why don't we say that? Now, that is a place where we can begin by making sure that our juniors know to address every patient by their name, not by their room number or their abscess or their disease condition. So the closing, in terms of closing thoughts, this is what I have to say. Communication is not an extra skill or a soft skill, as Dr. Indu said in her introduction. It is very much an integral part of clinical care. It's time we put aside this thing that communication skills come as we grow into the profession. No, we have to make an effort to learn it, nurture it, and improve on it constantly. Because good medicine is not just what we do, as I said earlier, it is how we do it. Most people will not even remember the prescription that we gave. In any case, it may not make much sense to them, especially given the handwriting that most of us have. But what they'll remember is, doctor was nice. He spoke to me very friendly and things like that. Because our words can heal or harm. Now, talking of healing and harming, I don't know if I put it in the slide or it's going to be in one of the other slides. There are two movies that I would like people to try and find the time to see in all our busy schedule. One is called, let me see, one is called The Doctor. It's an old movie made in 1991, freely available on YouTube. The other is called A Mistake, which is a 2024 movie, still a paid one, but I'm sure we can work around how to avoid paying for it. Most of us do that. So these two movies repeatedly reinforce and very, very humanely reinforce the idea of empathy being important to everyone. And that brings me to the second of the thoughts that I would like to leave you with. We, as technically qualified and diagnostically skilled people, whether it is in terms of or being a doctor or a nurse or a paramedic or a radiographer, whatever, we are second to none in the world, to anyone in the world. And those like me who have worked abroad will be able to endorse this. We feel very soon when we go for even training, we feel that we are on par with many of the people who are already there for some time. So why don't we think of combining that technical excellence with a little bit of that magic potion called empathy? And then suddenly we are not trying to catch up with global standards, we are setting them, as I think we should, as I think we can definitely do. All that I've said is easily summed up by this Sanskrit shloka. Let me put in the English version as well so that everybody can read. Atmanaha pratikulani paresham na samacharet. Nothing new, because once I write the meaning, you will all know we have heard this many times during our medical career and even if we are not in the medical field. Don't do to others what you don't want others to do to you. Putting it positively, do to others what you would want done to you. And that becomes a very important thing when we realize that sometime every one of us, doctor, nurse, any other healthcare worker, can and probably will become a patient. How would we like to be spoken to? How would we like to be treated, not as in medication, but in terms of human relationships, how would we like to be treated then? Here it is. These are the two movies that I wanted to mention. But the point is, this is the essence of what I wanted to say. And thank you all for listening. And I sincerely hope this leads to a little bit of discussion, at least, so that we all learn from one another. I would like to place on record my gratitude to many of the seniors who have groomed me and many people who have been role models to me, even though they were not my teachers, and especially juniors who have taught me a thing or two every once in a while, and patients who have come back to me with love and told me that they liked this about me, they liked that about me. They might not even remember that I did not help them for the condition that they came to me with. And when this happened very recently, I felt that 50 years of time spent in the medical field has been extremely rewarding. And together, as I said earlier, we can make our Indian way of healthcare provision exemplary for the rest of the world to follow. Thank you very much. Dr. Vidya, I have finished.
Over to you, Dr. Indu.
Thank you so much, sir. Very beautifully done. The whole topic, I think we can all clap for him. Especially taking us through the journey of Patels and Solkars. We did get to see the difference between a good doctor and I wouldn't say bad doctor, but doctor who is not aware how one should be conducting themselves and what is asked to a clinician or a doctor. Very, very well done. Before we actually start with the discussion, I would actually want to introduce all of you to one of the guest speakers here with us, that is Miss Madhu Mathur. She's here as a participant and also as a speaker who wants to share her experience with healthcare professionals. And I think that's going to be a great learning for all of us to understand things from a patient's point of view or patient's family member point of view. So before we start having discussion, I think it'll be good to listen to Madhu Mathur's point of view. So over to you, Miss Madhu.
Hello. So I am a patient as well as I've taken care of a seriously disabled child for over 30 years, and in which connection I got to meet a whole lot of doctors, some of whom were wonderful people and friends for life, and others whom I would really be unable to call anything but terrible human beings. And I just saw a comment. So before I share my experience, I just saw a comment from somebody who said that they'd much rather be managed by a skilled doctor with poor communication skills rather than a bad doctor with good communication skills. Here, I want to just give you the example of one particular pediatrician I happened to visit with my severely disabled daughter. And he turned around and told me, why do you even bother with her? She's going to be a vegetable all her life. So, I mean, would I ever go back to that doctor? He may be a brilliant doctor, which he is. He's one of the best known pediatricians in Delhi today. But this is what he communicated to me. So, I mean, I don't think I would recommend that doctor to anybody. He may be the best doctor in the world, but he's a bad human being. And that's what matters to me. So, I mean, now I'll get back to what I was talking about, what I'm supposed to be talking about. And that is, I'll begin by telling you that I'm the kind of patient whom doctors probably detest, because I'm the kind of patient who goes with a whole list of things I want to ask the doctor. And the list can go to 20 points until I'm satisfied about each point. I will not let the doctor go. So, I mean, they look at us and they see my husband and me walking in and they'll say, okay, where's your list? Let's take it out. I mean, the doctors who know us. So I'm that kind of a patient. And the other thing is I shop for doctors. I'll go and meet 5 doctors in different hospitals if I have to before I decide, okay, this is the doctor. And what do I look at? Basically, it is the communication skills. Is this doctor able to convince me that he can take care of me? Is he able to understand my problem? So, yes, I shop for doctors. I'm, guilty as charged. And I'm very proud of it because it means that I get to see the best doctors who will be good for me. I mean, I don't know whether they are good doctors or not, but they serve my purpose. So now I'll begin with one of the really bad doctors that I have come across, if I may say so. You can judge whether what you think of it. So this is a story from last year when my mother had to be, she is 94 years old, and she had to be admitted to an ICU with vomiting, inability to digest anything. And they told my family, my brother and his wife, that, okay, she has typhoid and we're treating her for that. But 2 days later, they stopped the typhoid medicines and they said she has a weak heart. So, yeah, we know she has a weak heart. So then they told us, okay, she's having a breathing problem. Let's put her on oxygen. So she was put on oxygen. And then they said she has a clot in her brain. We've done a CT scan and she has clot in her brain. So we said, okay, let's see the CT scan. And we consulted a neurologist and who said, look, I see no signs of a clot in this thing. So we tried to ask them, has a neurologist been consulted? So we found out no neurologist has been consulted. No cardiologist has been consulted. No lung doctor has been consulted. And what she is being treated for, we have no idea. So I wanted to go and visit her. I live in Bangalore, so I flew down just for a day to go and see her. And my family persuaded me. See, they were very much in awe of this very senior doctor. So they said, I mean, we can't talk to him. He has this aura around him, and we're scared of talking to him. Secondly, we've got into this hospital with such difficulty. No, none of the hospitals, they see a 94-year-old patient walking in. Oh, our figures will go down if she passes away in the hospital. They wouldn't admit her. So they ran around with her across hospitals till they got in. So they said, we can't question a doctor over here. Then thirdly, if you question a doctor, I mean, this may sound very bad to a doctor, but one reason patients are scared of questioning doctors is, I have my patient lying there in the ICU, a helpless patient lying there in the ICU. What if they take it out on my patient? So I'm not going to talk to this doctor. I'm not going to find out. So anyways, they said, okay, you have a lot of experiences with doctors. Why don't you talk to the doctor? So I said, fine. So I introduced myself. I said, look, I'm her daughter and I'm visiting. And I would like to know what is wrong with her and what are we treating her for. So he looked me up, down like that. And he says, are you a doctor? So I said, no, I'm not a doctor, but I would like to know what's wrong with my mother. So he said, if you're not a doctor, what are you going to understand? Aapke kya samajh mein aayega? So I said, okay, I may not be a doctor, but I would still like to know. And it so happens that my son is a doctor. So if you tell me what is wrong with my mother, I can convey to him at least what is wrong with her. So he said, let me talk to your, then why doesn't he call me? Your son can call me, he can talk to me. So I said, yeah, but I mean, meri baat karaiye. Let me talk to him just now. So I said, he can't talk to you just now. And I made the cardinal error of saying, my son is in the US and he can't call you and he can't talk to you just now. Now, immediately the whole atmosphere in that group changed. Oh, America mein hai. He's in the US, huh? So what? Look at my team. All of these people here, all of them have brothers and sisters in USA. So if he is in USA, so what? So I said, I mean, it's not my, I was absolutely stunned. I mean, I didn't know how to react to that. So in any case, I mean, I'm just telling you that I never got to know what was wrong with my mother, and she passed away a week later. That's a different story altogether. But none of us ever got to know what exactly was wrong with her. And what she was treated for, we don't know. And by the way, when I asked he said, okay, you can take my number from one of the team members. The team member said, we don't talk to patients. We don't talk about patients on the phone to anybody. So we can't give you his number. So that was the end of that bad story that I was talking about. Now I'll come to a good story which happened with me just last month. I required a coronary CT angiography, and I visited this hospital in Bangalore, and early morning we were called, and so when I went in, they explained to me. They said you need the cannula, so they put that butterfly thing on my wrist, and they told me to change, and I was sitting there, and then I think he was a resident doctor there. He came up to me with the consent form, and he told me, ma'am, we need you to sign this consent form, but let me explain to you first what it is all about. So he sat there and he explained to me, he sat next to me, he explained to me, okay, we'll be doing this procedure with you, and it's actually a harmless procedure. So I said, no, but I was reading somewhere recently that they say above 70, you should be careful about this procedure. He says, yeah, I mean, it is there, but we've done your creatinine is one test that we do. We've done that. That's normal. That is one of the things that can happen. So no, you're going to be fine. And we'll be observing all the time. Yes, there are complications. Sometimes they can happen. But we are there to observe all the time while this procedure is being done. If you feel uncomfortable, you can just wave or you can just speak up also. But you try to be very quiet. You try to be very still, because I said, how much time does it take? He says, that depends on how quiet and how still you can be. And he grinned at me and he smiled at me. He said, I'm sure you can, be quiet and still, and you can be out in 8 minutes, but it can even take 20 minutes if the patient is not cooperative. So, anyways, I mean, what I'm trying to tell you is, so well he explained to me the whole thing, and he said, "Don't worry, we are there, we are observing." And after it so happened that in 8-10 minutes the procedure was. Then when I came out, they said, "Oh, ma'am, you did so well, and it went off so well." And while I was waiting, one of the technicians called me in, so I was a little scared also going in, and he showed me my on the screen, he showed me all the images, and he said, okay, you can see your heart here, and you can see the blood flowing here, and you see that there's no problem anywhere. And he explained to me all the parts and how the blood was flowing, and he treated me like some intelligent human being who can understand what he's talking about, and who can appreciate. And just the fact that you're treated as somebody who is intelligent and who can follow you is a big plus. Instead of being told, you're not a doctor, why should I tell you? That kind of a thing. So, those were my two experiences that I wanted to talk about in terms of communication skills.
Back to you, Dr. Indu. We'd like to hear your comments and your
Sure.
thoughts on this topic.
So thank you, Ms. Madhu. I think you brought in a very important perspective, which we usually are not very conscious of. Though we may know, but we really don't acknowledge or we don't try to really work on it. And I completely understand. I think patients now have to be taken seriously because most of the people are educated and they are aware, they have access to information, they are able to read about their disease condition. Of course, they'll have a lot of questions about their health, which can only be answered by the treating doctor. And therefore, I think treating doctors should make use of this opportunity because they know best about the disease condition and also about the patient's condition. So they can really answer the questions and win their patient's concern, but win their confidence. But I think that's one thing that we really need to look at. And I think this example that you shared, Ms. Madhu, something very similar happened in my own, family's case. My brother-in-law had to undergo angioplasty. So my husband took my brother-in-law to one of the doctor in Delhi, who is a good cardiologist and he was known for good work. So, I mean, I was there with them, both of them, and we had a couple of questions to ask to the cardiologist. But unfortunately, like Dr. Hari Krishnan talked about one of the cardiac surgeon who was not willing to answer any question, we were given the same condition, don't worry, nothing will happen. We will talk about stents once we have to put it. So I had a question that once you will have a stent to put, then you will not have time to talk to me. I think this is the right time to talk to us. But then somehow he did not answer any of our questions. Still, we decided to go ahead with the angioplasty, thinking that he's known for his work, so let's take that. Like one of the participants mentioned, that I would rather go to a doctor who has a good hand or good skill with average or bad communication. So we agreed for that. But incidentally, we went for second opinion to another doctor. And I think most of the patients now don't hesitate going to multiple doctors because they want to be very sure that they are in safe hands, and also they get the best of the treatment and opinion. So we went to another doctor, and that doctor was really, really very kind and very, open to discussion. He tried explaining everything in very simple and easy terms to for my brother-in-law. The moment we came out of the consultation chamber, my brother-in-law said, "I'm not getting myself operated by the previous doctor. I'm going to go to this one." So I think this one example opens a very clear, gives a very clear message to all of us that if you want your patient to stick with you, you really need to understand your patient's concern and address them. So we don't like patient window shopping, but I think even in our own personal case, we will never hesitate going to multiple doctors for opinion because we want to be sure of the treatment. But at the same time, I think the onus falls on the clinician to explain and answer the questions in a very honest and transparent manner and with patience and in a language that the patient can understand. And trust me, patient is all yours. They're not going to go anywhere. They're going to stop with you. But I think that's the challenge that we have to take. That's the change we have to do. I think that's a beautiful narration, Miss Madhu, you have brought in. I mean, it's a cherry on the cake what Dr. Hari Krishnan was talking, and you have really shared your experience, and everybody will, agree with you. So I think with this we can open the house for question, answer, and discussion. I'm sure a lot of you must be, having a lot of questions to ask, and I have actually seen number of questions in the chat box. We can pick some from there also, but if anybody would like to.
So I was just going through from the top. So one of the first ones that struck me is by Dr. U.S. Dadwal. Can true empathy in medicine be taught and sustained through training and institutional culture, or is it mainly an innate personal quality? Dr. Hari Krishnan would like to take that.
Yeah. Dr. Dadwal, I think some people have a little bit more of empathy inbred in them as compared to others. But in the medical field, I think we all need to strive to learn and improve our level of empathy. And as I said in one of the slides, our empathy does tend to get eroded, even if you're to start with a very empathetic person because of various factors. So that's a time to sit back, reflect, and try and see what we can do to improve our empathy. And so it's a matter of being aware and being able to relate to the situation and improve oneself. Thank you.
Professor Sethuraman, would you like to say a few words at this point?
9 minutes, there's a power cut.
Okay, sir. We'll come back to you after a while.
Yeah.
So I have a point to add here, Dr. Vidya. I think it's always assumed that communication, empathy, these are already people know and they are practicing. But I think this has to be integrated in the program where we talk to our students, be it doctors, nurses, or any healthcare professional, and we actually let them go through some program where they actually experience empathy when they go through similar situation where they have some pain or discomfort or a critical condition and what emotions they experience, probably that will help them understand the emotions of the patients also. And of course, as like Dr. Hari Krishnan said, that some of us would be already empathetic, which could be a kind of an innate nature, but definitely everybody should undergo some training to understand, to learn empathy and also implement that in their interaction with the patients.
Dr. Sudarsanan has said that did not ignore the maddening hours the medical professional, especially junior staff and residents, undergo. Their poor communication may be accounted for by this preventable stress. So, would you like to say something about the organizational aspects of improving communication, Dr. Colonel Hari Krishnan?
Yes, I think the system
Hardly
plays.
focused on the individual level. So
Yeah. Well, I think the system does play a part in how things start to erode, as I said in one of the slides. I think we can try and improve this by being role models ourselves and trying to make sure that we allow some time for people to reflect. For instance, um, it may be fantastic that you spend 24 hours a day in the war, but surely, however committed you expect your juniors to be, there has to be time for them to have a cup of tea, lunch, go to the bathroom. Now, those are all institutional things that we cannot insist on, but it has to be practiced by us. Now, that will make a difference to how they shape up and how they become seniors when their turn comes. So, over a period of time, this balance between the systems and the behavior of the doctors and their role and their ability to communicate has to be supervised by the powers that be, I mean the administrators, and that is their role, and that is the important part of their role. Dr. Vidya, I see Dr. Professor Setraman is back on screen, so you might want to ask his.
Yeah, thanks, Dr. Hari, for your nice talk. I came to MAMC 3 weeks back, I think. I don't know if we met or missed you, perhaps. For Devendra Verma oration. Yeah. Anyway, this communication skill, we have been, I had a kind of eureka moment in 1987 when I took a feedback from alumni. In Jipmar on first Sunday of every August, all the alumni come. There are 188 people that day. And I just sent a small slip saying that if you were to join MBBS one more time in Jipmar, what are the things that you would have would like to be taught that you missed it in your first stint as MBBS student and all that. I was surprised that 188 people had written how to talk to patients, and 185 people had said how to talk to patients' relatives. Then other things were there: financial management, entrepreneurship, this, that, all. But the number 1 and 2 were all talking to patients and relatives. So then I had just like Hari raised, who teaches us communication skill? Nobody teaches. We had good role models and bad role models. So you learn from them. So then I said, no, it cannot be in Jipmar. We must start a communication skill. There is no book available, nothing. So I went in to library, picked up the social science journals and perspectives in biology and medicine. It comes a very good journal, Professor Chandrasekhar's most favored journal. So in that there will be articles. So I had a diary I kept on collecting for about 3-4 years. Then I had enough material to understand the nuances from psychological point, from medical point, from patient perspective and all that. So then we requested Dean, let us start an orientation program for interns, just a 3-hour module on simple do's and don'ts on how to talk to patients and all that. So one common mistake they do, which irritates, then that is one of the reasons why they get frustrated. They will tell the lady patient for 2 hours, 3 hours, especially in South. Then what happens is, 2-3 minutes they explain everything, and then she will go out and bring her brother or husband or father or someone and say, you will want to know all over again. So this is a common problem. So they used to start shouting at them. What do you mean? There are 100 people in the outpatient. You think I have no other? It goes haywire. So we do a role play of all these things, common things that happen in the other role play was a classical thing of without context asking question. The first they ask, according to the, what is your name? Mala, are you married? Yes. Then no, she will say no. Next is how many children? So how many children? Then she will get angry. See, actually happened. One of my 2 years junior fellow did that. So Dr. Asha, who was in ONG that time, she said, ask the other way, man. She was very busy. She didn't really think. The next patient came, said, what is your name? Sita. Then she asked, how many children do you have? Two. Then he asked, are you married? She got even more angry. So I was first year PG that time, posted there in ONG. Then I realized that knowing English is not enough to be a communicator. That is a commonest myth, that if I know language, anyone who knows language can communicate well. That is a total myth. Communication vocabulary in a particular language is just the foundation. But communicating effectively is an edifice that we build with skill and training and self-reflection and learning nuances of body language, para-language, language and all that. So that comes. So that 3 hours was not enough, but it gave a kind of curiosity for them to observe people, learn from good and bad behaviors. Then later, that is what I collected so much material, ended up as a book in 2000. Then second edition came in 2014, I think. And actually due for a third edition now. So that is all JIPMER based for 25 years of experience, 40 years actually, including my medicine student days. It's all distilled and put there under core skills and this skill. Then they asked, you written, but what is the use? So when I was vice chancellor here, a dental professor in prosthodontia, she wanted to do a PhD in communication. So then I had a great chance, 2015 to 2019, a 4-year study on the most difficult thing, completely edentulous patients, where full denture has to be fitted for both the upper set and lower set. So one of the most difficult things to satisfy patients. We took that as a challenge. He said, okay, we'll take third-year PGs and give them 9. I have a standard thing from the book, 9 sessions, 8 2-hour sessions. We trained each PG as a group. About I think 6 of them came, and then before they were trained, we took interviews from 50 patients on patient satisfaction. And then after they were trained, they underwent the training on core communication skills or do's and don'ts. And the last one, 9th, was actually a video recording which they used to do. We analyzed and pointed out what are the strengths in their language and body language and what are the weaknesses that they have to correct. It was a lot of insight for them and a lot of insight for us also. That personal coaching of everyone. That made a big difference. And then we followed up 64 patients afterwards. And we found there is a 7.93, can round it up as eightfold improvement in patient satisfaction, just on the basis of 18 hours of training. In a 3-hour PG program, given the small manageable numbers, can't we train our PGs? 18 hours of training, it must be integral part of core curriculum. Whether you call it soft skill, hard skill, or whatever, it's an important skill. And if it is going to improve patient satisfaction eightfold, and I'm sure if it had we tested it on patient relative, we would have achieved similar results. It has been published that our training methodology, she has copyrighted also. Dr. Varsha Murthy, he is in Pondicherry only, in Venkateswara Dental College as professor of prosthodontia. You can ask her to share her experience if you want. And so that even now I meet those former PGs who are now dental consultants. They say they are very happy. Patients are very happy even now. They thank me for training them and all that. So that happens. But the immediate feedback that you won't believe. They came bringing kilograms of jackfruit and cashew nut and all that. Said before the underwent communication skill, no patient ever gave them anything. But after this communication skill, they said after fitting the denture, most of them when they come for checkup, they always bring some goodies and share with them and thank them and go. So they used to bring and share it with us also. So that is, I think, a bigger feedback than all the written feedbacks you can get. What was given in kind. Thank you.
Thank you, sir. Professor Anandakrishnan, you had typed some comment in the chat box. We'd like to hear directly from you, sir. And also, extra question added is, does empathy decline under stress? And uh, how do we deal with compassion fatigue and burnout? AK, sir, are you there?
Yeah. I have written whatever I wanted to write in the chat box, Vidya, so I don't want to repeat what.
The chat box is very, very full, sir. So we'd like to hear it directly from you. Like,
the question is what I said, and I disagreed with one of the people, that skill sometimes is more important than communication. In my experience, and I have been a surgeon for 52 years, that's certainly not a very true statement. Because if you are like that from the beginning of your career, you will not remain a very busy surgeon after some years when people get tired of your gloomy looking face and grumpy behavior. So Vidya knows that. So that is not correct. The other thing is, somebody asked, and that's a good question. Do you have the right to ask about the diagnosis and what is planned? Certainly you have the right if you are the near relative or you're a caregiver. But every member of the family coming and asking, we do not even know the relationship, sometimes neighbors, it's unethical to discuss those details with all of them. That's sometimes the problem with communication. You tell two or three people of the close family, and then three or four more come, and you do not know whether they are how they are related, whether they are friends, neighbors, what they are, and then it will rebound on you. So one has to be careful. And as far as workload and burnout and all that are concerned, we have to get used to this lifestyle which we have chosen ourselves. And therefore, for that, I think communication is a very important skill. It can be taught, it can be learned, it can be practiced, and there is no excuse for doing it every time you have a patient who comes to you with some problem. Because I've been a patient many times in a hospital, and I've been quite upset with some of the doctors and the way they behaved with me, knowing that I was also a doctor, and their reluctance to talk. So it's very, very damaging to the psyche to meet that sort of situation. So I think I'm very glad that Hari raised this issue today. Very, very important issue. But the message is communication skills, empathy is not only intrinsic, it can be taught, not only by role modeling, but by deliberate activity, as Seturaman has already mentioned.
Dr. Vidya, Azim has his hand on for some time.
Yes. I was coming to him next. Dr. Azim, please. And then Dr. Bala.
Hi, I'm Dr. Azim. I'm a consultant ophthalmologist from Brunei. I've been following up your thing. It's very nice, and hearty congratulations to Dr. Hari, and very, very well done. And Professor Sethuraman's great points. I'd just like to share how I do it. Just as he requested, just to put our points in, and we can learn from each other. Basically, being an eye surgeon, I deal mostly with patients who cannot see. So when they come to me, sometimes they're bilaterally blind, cataract before they come for surgery. So the first thing I emphasize in my team first is right from the chain starts from the reception level, from the time the patient comes into the clinic, right from the time the billing is done and the patient goes. I work for a government setup, but everyone should be smiling. The voice should be very calm and empathetic. Patients feel the frequency actually more than actually they can see. So in my experience, right from the play, how the room is placed, how the ambience, there's quiet music in the room. When they enter in, they should feel that calm atmosphere. And the voice, how we talk to the patient. Many times I touch the patient. The patient will be in a wheelchair. I just touch the same, how are you? I'm so-and-so. I'm going to be taking care of you. And the warmth, they feel the warmth in your hand and the touch and the warmth. So many times after surgery, they come back and say, are you the one who saw me first? And, that kind of feeling is definitely there. So that is, they can feel the frequency. That is most important. That's how the ice is broken. And then I tend to remember the name of the patient. Especially, I just talk to the patient and ask them what is the profession, the small hobbies, like they like to play golf or they're good in making cookies. So when they come the next time, or I just tell my nurse, this patient, she's very good in making cookies. That's enough. That one statement is enough that the patient will think, okay, doctor remembers me very well. Everything is known. So even the attenders and the things, they become very close to you. So small things you remember of a patient, remember to tell that the next time. So even in theater, when they say, okay, ma, how are you? Now you can go and start making your cookies, okay? And so they know, oh, this doctor remembers me now. He from the consultation. So that makes a difference. And listening is most important. I just listen patiently. And after that, finally, I ask them, because now patients are very informed. They go to Google, they go to ChatGPT. So the next barrier is just listen. Whatever they say, just listen to them. And if they have questions to ask, I just patiently listen to them. And then after that, before I answer, I ask them, are you the focal person in your family? How are you related to the patient? That I filter first. If they say, no, I'm just the cousin of the patient, I said, okay, I'd like to talk to the person who's focused. Are they here? If the family, will give us separate counseling, we can explain details. That will save you some time. And then I asked, what are you doing? Not to put the patient's attendant down, but to know at what level I should talk to. If the patient's son is a mechanic, and I tell the eye is like a car headlight, I tell him, look, I'm a surgeon, I'm going to change the headlight bulb. If the reflector and the wires are okay, you're going to get good vision. But if the wires are already damaged, just by changing the bulb, the eye is not going to come back. If he's a computer professional, I say, okay, he's like a mouse and the wire and the laptop. I'm going to change the batteries. If the cable is good, then the mouse is going to work back again. If the cable is damaged, unfortunately, the change of batteries are not going to help. So just to know at what level I can talk to. Like Richard Feynman says, if you can't explain to an 8th standard student, that means you're not good. So basically, I try to make it as simple, short, and crisp, and then just to respect them. And then I tell them, look, if you want further details, we'll give a detailed counseling session. Please get the involved people all the involved people come in one go. So we'll explain everything to you so you know how the counseling has to be done. So that will save us time. At the same time, the attender feels respected. And the focal persons come in one go and say that, look, we have explained everything to you in detail, and give them a pamphlet. So that's what we try to do in our place. And then the voice always at all time keeps smiling. And then say, even if they keep a lot of asking questions, they say, okay, I'll explain it all in one go. Please let me know what all you want to know. And then finally, I say, okay, this is a link I can share and which you can search in Google, which will give you animations, which you can make you understand better. Then you just, if you can't understand it still, you please come back to me. I'll explain to you one more time. That makes a very big difference in the patient's thing. Finally, before I say, okay, they ask me for guarantee. Can I see for sure? I say even the best airlines in the world will not give you a guarantee it will land safely. There can be a safe airline, but not 100% proof. Only God can give you guarantee. I'm a human. So once you go down and humble and tell them, look, as a doctor, as a human, I will do what best I can. God gives you vision. So that's what I will do, and that's how I finally finish my counseling. That actually closes it. After they don't ask any questions, they're quite convinced that they know I'm sincere. And that is very important. The patient should know that you're sincerely trying to do. And as a human, you have your limitations. Once they know that, they're usually quite calm. So this is how I handle it. And so far, with God's grace, things have been going. I just want to share my experience. I would love to learn from senior people how they handle the situation similarly. Thank you for the opportunity.
Thank you, Dr. Azim. Dr. Bala, you have your hand up.
I'm connected to healthcare industry more as a patient rather than as a doctor. I'm not a doctor. Dr. Hari knows me that I'm not a doctor. And Dr. Azim very coincidentally mentioned aviation industry. That is the industry I work for the past 48 years. And I'm working at a global level. And what brought me very close is, of course, Dr. Hari, and also communication skills, because I do that for my industry throughout the world. And in that, one of the points which Dr. Hari brought out was excellent. We technical people slip into jargon unknowingly. That is so common. So we need to be so conscious when we talk to non-industry person. In your case, from a doctor to a patient, mostly. In my case, from probably an aviation person to a passenger. We need to be very conscious of the fact. And empathy he talked about. I recently had, of course, not a very welcome one. I had to go through an angiogram exactly 3 weeks back. Dr. Hari knows that. And I had met one of the best cardiologists who literally seemed to have gone through all these slides because he did everything correct of what Dr. Hari said about. First, took empathy, wanted to know my background, like what Dr. Azim said, because he wanted to know at what level can he communicate with me. Then when I said my background is this and I'm doing it at a global level, he was so happy. So he started asking more about aviation questions to me. And then later on, he explained, as Madhuji also mentioned, he explained very clearly what it's going to be go through and where I'll get the pain, where I should be. I was very happy at the end of the day. Everything went well. Next checkup is next Thursday, 21st of May, because I've got one more block. So he is going to look into that as to what we are going to do. So I cannot overemphasize the session that is being done today. Dr. Hari, once again, excellent and thank you, because I firmly believe in that irrespective of the industry you belong to. You may belong to medical industry or one. And in all these industries, medical industry, healthcare needs it more than others because psychology is involved. And people's also, I had a very funny thing which my cardiologist, sorted it out very well. The person taking my vitals were close to being very rude. Literally, my blood pressure would have gone 10 points up because of that. I think not because of my body. Doctor understood it and he handled it so nice, so nice. And really is one of the best doctors I've ever seen there. I thought I should share that experience with you. Thank you, Dr. Hari, once again for inviting me.
Thank you, Mr. Bala. AK, sir, you have your hand up. Did you want to say something, sir?
Is there time, Vidya? I've already spoken.
Yeah, no problem, sir.
Yeah, two things. After hearing Dr. Azim, I am reminded of two instances. When I took my mother for a cataract, and they gave a consent form. It was brought by a nurse. Nobody talked to her or to me or to anybody else. And the first paragraph was, you are having your lens removed and then replaced with another thing. The eye can get infected, and therefore you can lose sight in this vision. Sometimes that results in so-called, exactly, sympathetic ophthalmitis, in which you can lose sight in the opposite eye also. This is the first 5 lines of the consent form which they gave us to sign. And then after I signed it, they brought another consent form. And I said, what is this for? This is high risk consent. And why? Because she's aged. I said, cataract is disease of old age. Everybody will be aged. But no, you have to sign 2 consent forms. This has happened in a very famous hospital in Chennai. And secondly, when I went for my cataract, they gave me not only topical anesthesia, but gave a periocular block. And when I recovered, I saw everything double. Now, nobody had told me why I was seeing. I thought that the intraocular lens had slipped out of place, and that's why I was seeing double. I was so worried. I asked for the doctor and she said, no, this happens. We have given you extraocular block. You will get paralysis of the extraocular muscles. So till they recover, you will have diplopia. So how much anxiety that causes, just the lack of empathy and communication. It could have been avoided by just telling that this is possible, it is normal, expected, and you will get back your proper vision after that. You go for cataract and come out seeing everything double, naturally you get worried. Dr. Azim? So,
Dr. Azim, you're muted. Dr. Bodapati, you have your hand up. Sivaramakrishnan.
Thank you, ma'am. I'm Dr. Sivaramakrishnan. I'm a student of Dr. Hari Krishna. I have been his student when I was doing my MS General Surgery, not very long back, to be exact, in 1996. And unfortunately, with this constellation of group, I realized I'm just a teenager. I was a consultant in surgery and urology. I was a professor and teacher in urology and general surgery in the armed forces. Thereafter, I worked as professor of urology and HOD at Devrajas Medical College. Now I'm having a small stint and go at practicing urology in Port Blair, Sri Vijayapuram, that is. So communication, I realized, changes depending upon where you are working also. Dr. Hari will tell you that talking to Goop Singh requires Goop Singh's knowledge. And when Professor Sitaraman was telling me about it, you not only need to know the language, you need to know the social circumstances under which to communicate. Like it's quite common in the USA for a lady to have two children and not be married. So that married is an extra social question to know if you have a social companion or not, I guess. One aspect about communication and empathy after coming to the islands, I realized is it's not necessary that the immediate relations are the persons who are the people who are looking after or who are the, so to say, as we call next of kin. More often than not over here, you have friends who are the persons who are the companions and who actually look after and sort of actually are the next of kin. The reason is because there are two types of people over here. One is the islander people. Those people, they may be in the North Islands, but they come and work in Port Blair. Or people are mainlanders. That's the word that's used over here. So the people are coming from India. Anybody coming from India are called mainlanders. So they are working here as a team. So when it comes to giving information, discussing options, you actually may not have a next of kin with you. So you need to be sensitive to this particular aspect. So to be aware of social circumstances, like Professor Sethuraman had pointed out, is absolutely valid and correct. And I think, empathizing and communication, in my opinion, has to be situational. This is what I thought in my short experience across three different aspects of profession. First, as a military doctor, second, as a teaching doctor, and now as a private practitioner.
Thank you, Dr. Shivaramakrishna. If anyone else has any questions or comments, please put your hand up. Because, like I said, the chat box is exploding. I'm trying to keep up.
Dr. Vidya, I just want 1 minute to comment
Yes.
on Dr. Azim. He gave very good examples of how to communicate depending on the patient's profession and what he or she is comfortable with, the vocabulary. The word for that he didn't use, it's called NLP, not natural language processing. Now if you put NLP, it will go. Original old NLP was neuro-linguistic programming. So if you put neuro-linguistic programming, there are YouTube videos on that. There are several techniques, mirroring and other things. One of the important one is to use the vocabulary that is comfortable for the person that you are talking to, whether he's a school teacher, he's a policeman, a sportsman, or an electrician, or a computer tech. So accordingly, you use the vocabulary, or a illiterate villager, or a highly sophisticated billionaire. No, our vocabulary has to change accordingly. So that NLP is a very good technique. If that's one of the advanced techniques of communication skills. Thank you.
Thank you, sir. If we have missed any of the questions or anybody who commented at the chat box but would like to speak up, Dr. Mala, we are happy to have you. Thank you for taking time off from your schedule.
Not at all. And thank you so much, Dr. Vidya, and you, Hari, and Dr. Indu for a superb presentation. My goodness, this is so enlightening. I wish there had been a large audience from the UK, where I'm based, listening in to this particular session. So thank you. The reason why I am particularly interested in this is that, firstly, of course, Hari and I are classmates from Maulana Azad. He was my bestie during my college years, and so I've known him for far longer than I'm going to divulge at this event. But I came into the whole issue of language and communication in Britain in the NHS, where I've worked either in the NHS or with the NHS for the best part of 4 decades, because there was this assumption that racism was at the root of disproportionately larger numbers and proportions of ethnic minority doctors in the UK failing postgraduate exams and disproportionately greater representation in the numbers who were complained about to the regulator, the General Medical Council. So in 2014, I wrote a report. It ended up getting launched in the House of Lords, which is the kind of Rajya Sabha of Britain. And then from there, this race equality strategy emerged in the workforce. And one of the things that was discovered was that international medical graduates who come into Britain, and Indians are the largest number, they get no induction. So there they come with incredibly bad habits and poor learning, as we've all seen, having graduated in India and community, that we don't come prepared. It's not as if communication is taught was taught. And the other thing is then, because, and I loved what Professor Sethuraman said, vocabulary isn't the same as being a good communicator. So in Britain, there was this whole thing of, oh, he speaks English. When I ask him some basic questions, he seems to know how to answer. And of course, they're brilliant clinicians. So get them in there, give them a pager, get them on the wards, and they start working. And of course, everything goes wrong from being completely unintelligible. There are even, not just Indians, but also from other parts of the world, doctors, and I've met them. I can't understand them. That's the kind of accent they come from, all the way to that arrogance, and this sense of I don't need to talk to you for very long. I'm there. My job is to do the surgery. To the other bit, which we don't seem to learn, that about the patient being equal. And here, you're talking about an elderly patient together with perhaps the daughter and a son-in-law or some such thing, but you're talking to the daughter and son-in-law as if the lady of 95 doesn't matter. So who you're talking to matters in Britain, and they will complain to the General Medical Council, and you will get into very, very hot water. And the same applies to children. You talk to the child, assuming that the child is old enough, say 4 or 5, and able to have a little bit of a communication with the doctor. So I ended up setting up an induction program, which included language and communication for overseas doctors, and that's now a recommended induction for NHS England. And the reason why I'm mentioning all this is it would be absolutely fabulous going forward, because there is still this assumption in Britain that, from the Commonwealth and particularly from India, they come with good English skills. We don't have to invest any more in teaching them how to communicate, and they do, because you're disadvantaging them by not teaching them communication skills. Communication is a very important part of the medical curriculum in Britain. The Indians aren't getting it. Presumably other people from other parts of the world aren't either. And you're actually tying their hands behind their back if you don't give them that extra investment. And to have a little group of you help me through a kind of network, maybe Hari can set it up with you, Dr. Vidya, and you, Professor Sethuraman, and a few others who might be, Dr. Azib. My goodness, it'd be lovely to have all of you come as a group and just, have a session with the General Medical Council and the system leaders in NHS England about why you, as a representative of those people, they don't want to criticize, but saying, no, we deserve to be self-critical and recognize that our communication needs to improve. There are many people in India who get it incredibly right. There are many, many rude white doctors in Britain. However, the best doctors in India and the best doctors in the UK recognize the importance of communication. And we need to do something to ensure that all international medical graduates who come to serve in the NHS have that understanding and the extra, call it communication, call it training, whatever you wish to. But they deserve that in order to ensure they practice to their best potential. So thank you, Dr. Vidya, for letting me speak.
Thank you, Dr. Mala, and we look forward to your session in the coming months. Venkateshwar and Mahadevan, you have your hand up.
Yeah. I'm Professor Mahadevan, and I'm a professor of respiratory medicine at the Norwich Medical School at the University of East Anglia in Britain. I also chair the Clinical Examination Board for the Royal College of Physicians. And as such, I go all over the world, including, multiple, sort of hospitals in India, where they conduct the postgraduate membership of the Royal College of Physicians, MRCP clinical exam. And I think I fully endorse everything that Dr. Mala Rao has sort of said about communication skills in general, and how this needs to be increased, particularly not only in Britain but elsewhere. And I would be very, very happy to sort of join her and others to sort of see how this can be enhanced in the future. Communication skills is a very important aspect of training in all the medical schools in the UK, including the one that I'm associated with. And as far as coming up with when I go to examine for this membership exam, what we find that the Indian doctors are very, very good at picking up clinical signs, which is one of the skills that they've got to pass in the exam. But generally, they come up quite short when they've got to communicate, a particular diagnosis, or when they've got to communicate bad news, which is one of the components of the exam. So therefore, what I have done is I have advised the Royal College of Physicians that it is unfair to be running this exam in so many centers all over the world, including India, and just failing these candidates in communication skills because they haven't had the appropriate training. And so, this is something that I'm hoping that Dr. Hari's, training will sort of enhance. And I'm very, very keen to sort of, incorporate that into, some of the existing training modules that the Royal College of Physicians use. So I've known Dr. Hari for a very long time, and we are very, very close friends. And, I joined this chat. I joined the talk a little bit late because I had to finish my outpatient clinic this afternoon in the NHS. But I, fully endorse what he's doing, and long may this, go on. Thank you.
Thank you, sir. If anyone else has any questions or comments, please turn your camera on or raise your hand. Meanwhile, over to you, Radhakrishna.
What a wonderful session this is, and unforgettable really. And I think this has got the record audience in Marvelous Medicine the last 5 years, 160 plus. I think that says a lot about the speaker, his contacts, and actually the the valuable comments by such senior and eminent physicians who stayed for so long speaks volumes. The first thing Vidya decided is that I'll have a photograph of Dr. Hari Krishnan in my room. So looking at him, I understand how bad I am at communication. I'll give just an example of my today's proceedings. There's a patient who would require a cholecystectomy, just walked in, and just then I got a call that the patient in the theater is scrubbed and ready. I just rushed in 5 minutes and I told you require a lap cholecystectomy. And the patient asked something. I told my assistant will talk to you and went away. When I came back after surgery, another patient with inguinal hernia is again waiting. 5 minutes later, I had to attend a nutrition meeting and I had to be there. Same 5 minutes. I felt so very bad. I didn't give any excuse why I'm doing it. And listening to the lectures today, I felt so bad. But the icing on the cake, Vidya, I should tell you that one of the patients who operated today, I always make it a point to go before the patient is anesthetized, hold her hand, whatever. Then I just put my head on her forehead and said, "You'll be all right, don't worry." You know what she said? "I know, doctor, you're from Jipmer and you'll be good." I mean, this is something, that carried my day. Thank you, sir. It's wonderful. And I'm sure once again, you, Dr. Malarao, and Dr. Venkateshan should come together and teach us Indians as to, what more in communication we need to know. We'll have a couple more sessions and we'll be very, very privileged to have you, sir. Thank
If there
you.
are any younger teachers in the audience after the new, curriculum in MBBS, I think communication is being actively taught. Probably the first batch should be reaching final year or just passing out now. So, have you seen any difference uh, in the communication skills of these graduates as compared to the rest of us who passed out some time back? If there's any younger faculty in the audience, we'd love to hear from you. Meanwhile, Dr. Hari Krishnan, you're trying to say something.
Yeah, no, I just wanted to say, Dr. Patta, you are being a bit too severe on yourself. It is not wrong. It reflects your popularity that you are very busy. I would simply suggest that you have an able and sensible assistant whom you can delegate this responsibility. Listen, I don't have the time to explain to her what a lab coli is. Would you mind spending 2 minutes and explaining to her? I think it would be equally appreciated like it is coming directly from Dr. Patta Radhakrishnan, who they want to be doing the surgery on. So I think there are ways around. I'm sure you'll agree. Yeah.
He has three wonderful physician assistants who will take even an hour if required to go through the patient. So
Good.
that part is sorted.
Yeah.
Bani, you have your camera on. Did you want to say something?
I just want to respond to my two teachers. To Dr. Sethuraman, I want to answer the survey that JIPMA taught me dedication and Kasturba Medical College Manipal taught me communication. And when I went to St. John's again, I saw that the PGs were not communicating with the patient. So we use, I don't know whether we use a government hospital and a mission hospital, busy part as an excuse. But JIPMA taught me dedication, Manipal taught me communication, so I was good. I mean, hopefully I was good. And I wanted to say one more thing. I forgot. It's okay. It was.
You said
Yes.
AIMS and PGI.
One more thing I want to say is, yes, and I said AIMS and PGI teaches you how to write papers. So my boss in Manipal wanted me to write papers, and I was a great disappointment to her. So different colleges, depending on their values, teach you different things. And I want to say one more thing, that I much rather have a skillful surgeon than a talking doctor, because I'm a doctor. So I went to the best non-speaking doctor for some surgery. I won't say which surgery, then you'll guess. And I went to a student of mine in Udupi practice and asked all my questions, like what should I do, what should I choose, like lens for cataract, or choose lens, right? So I much rather have a skillful surgeon because I'm a doctor. But if I'm not a doctor, I would go doctor shopping. I would do Google search. I would look up ChatGPT. That's what's happening these days. So our life was easier. That's all. There's a difference if you're a patient as a doctor and as a non-doctor. And once you retire and you become patient party very often, then you realize how you've kept 200 people waiting in your OPD. Thank you very much. It was a very nice evening.
Dr. Soames, you have your hand up.
Good evening, everyone. I'm Dr. Soma Ganesh. I'm
Hi,
sorry.
Soma.
Yeah. Hi, ma'am. I'm sorry I couldn't switch on my video. I'm just in a vacation at elsewhere in India. So I think Dr. Vidya ma'am asked about experience with newer generation. So I take this communication class for my postgraduate residents personally. So I usually take that class myself. So for a 2 hour, 1.5 hours class in the morning, so I sort of did a role play and how to communicate, how to hand over, how to train residents in different ways. So once I think a couple of months ago for the newly inducted first year postgraduate MD anesthesia residents, so I was telling them this tool of CUS tool, that's a communication tool, which is, it's a graded assertion tool, especially when we have this, we have to raise the safety concerns and stop unsafe behaviors, especially when we are working in a hierarchy setup. So when your first year student is working with you, and when the first year student is going to talk to a senior consultant or a professor and how they can safely express themselves. So I was teaching them that you can tell that I'm concerned that the BP is falling, or I am uncomfortable with the way the vitals are seen in the monitor, or I feel patient safety is compromised, or I would like to stop and take a step back and think what's happening. So I was training them this CUS tool. And then after 1.5, 2 months, there was a sick laparotomy at middle of night I was doing. And then I was busy putting a central line. And then the first year resident told me, sir, I would like to raise a concern. I'm concerned the BP is falling. Would you like to start an noradrenaline? And the input from all the senior residents that I have been working with, that postgraduate is little introverted, he will not communicate and all. And then at the right moment, he just told me what is concerning him. And then he told me, sir, you taught me about all these steps. And then after I started talking with different senior consultants, they were telling like, after you took over this communication class, this batch of students are really good at communicating. They are improving a lot. And then incidentally, this is the first batch of students, a couple of students who have completed this ADCOM module from the NMC curriculum. So they have undergone this attitude, ethics, and communication skills during the undergrad, and then probably the 1.5 hour program, which I conducted as sort of a role play rather than a lecture or something. So we had some 5 minutes role play for some 5-6 scenarios, and then quick take-home messages out of all the acronym-based, mnemonic-based learning tools, which I shared them as well. So now they're all communicating. They're using SBAR where it is needed. They're using CUS where it is needed. So they are using iPass baton where it is needed, and so on. So that was one thing I would like to share. Yeah, thank you very much.
Fantastic initiative, Som. Your postgraduates are indeed lucky to have you. Your closing comments, Dr. Indu. I think we are really out of time. Way past our time.
I think the whole discussion has been so enriching and full of learning. I think I would give complete credit to Dr. Hari Krishnan to have started this discussion, and everybody has taken it with a great interest and they've shared their experience. Thank you so much, Dr. Hari Krishnan. I think this is the beginning. I hope that this topic is discussed more and more in the time to come. And as I look forward to comment by Dr. Mala and then Dr. Venkatesh, that it should be taken at a not only at the postgraduate level, but even for the international migrant doctors, even they require this training. And I do hear this very often, that doctors from India are excellent at clinical work, but when it comes to communication, assessment, they are not really able to make really good decisions. But this is something that can be addressed and that can be taken care of. Thank you so much, everyone. And thank you, Dr. Hari Krishnan, for the wonderful talk that you had. Thank you. It was beautifully done.
Your closing comments, Dr. Hari Krishnan.
Dr. Indu, I fully agree with you. I think we must make a concerted effort not only to educate communication skills to our people for dealing with our own, but because we are so welcome in other parts of the world, we must try and make sure that we create an awareness of how communications are different in different parts of the world, like so beautifully brought out by Shivaram Krishnan and Dr. Azim and all that. So I think we have to try and do something worthwhile. And Mala is a, I don't know if she's still there. If she's not there, I can share. She's there?
Yes. Yes.
Okay. Well, I didn't want to
I'm
give
here,
her
Hari.
I don't. You please take care of your head, because I'm going to tell everyone that Mala, in my sincere opinion, is one of those people who is really going to make it to the highest level in the health ministry and healthcare in the NHS. She deserves it. She's already an extremely decorated person. But if she says this, it's something that we should take serious note of, and we must do something from our side to help our own youngsters who go abroad and earn a good name for us. Dr. Vidya,
KJ
Dr.
has his hand up. KJ.
Yeah, KJ Singh. Yeah, he is one of my most favorite students. I'm sure he'll come up with something worthwhile. He's a wonderful surgeon himself.
Could you please unmute yourself, sir?
KJ, unmute yourself, please.
Yeah, am I unmuted?
Yes, we can hear you, sir.
Yeah, okay. I'm extremely sorry. Actually, I'm traveling and I'm in a vehicle, but I just had to attend this conference and presentation. And I very briefly, I'll tell you, I've been a Professor Hari Krishnan student. He's like a godfather, a mentor. Every word that he's spoken today, he's actually walked the talk. We've learned so much from him, and it's a very ill taught subject in medical profession, and very important. And the key word that he's taught us is not to be very fancy, be very simple, very honest with the patients, and there's never a problem that's going to happen. In my now 35, 36 years as a doctor, I've followed this and I've never had a problem with any of the patients. So thank you, sir, for being there for us and for lots of other students while you were in AFMC, in the army, and later as a civilian. Thank you so much.
Thank you, KJ.
Thank you, one and all. Actually, this is probably the third or fourth time we've had a session on communication in marvelous medicine, but the overwhelming response shows that we could do it any number of times and it would still be relevant. We'll meet again next week with another episode of Marvelous Medicine. Till then, take care.
I think Dr. Indu was raising a finger. Probably she has a closing
I just
statement.
wanted to inform everyone that I hold a master trainer program for people who are interested to become trainers in healthcare communication. So Dr. Soma Ganesh, I think, has attended my program. I don't know if he's the same person or I'm talking about somebody else. But I mean, it's a 10 weeks program, and we meet once in a week for 2 hours and discuss various topics related to healthcare communication, so that that information can be imparted to medical students and postgraduate students and other fellow faculty also. So that something like that also could be considered for some programs. Yeah.
Thank you, Dr. Indu. Perhaps you could send me some details which I could then share in the broadcast list, so that whoever's interested could get back to you for your Train the Trainers program. So again, thank you everyone. We have 53 people here at the end of 2 hours, which is like really some kind of a record. And like Radhakrishna said, we had over 160 people logged in at one point. We hope to bring such relevant topics which will be useful and interesting to everyone. Thank you everybody once again. Good night.
Thank you. Good night, everyone.